We have Dr. Abney here today. We also have Dr. Murphy that I am going to turn the floor over in 1 minute. I have a few announcements. If you want to ask some questions, please put them in the chat box and we will have Dr. Abney answer your questions. And 2, there is closed caption services for this presentation. If you go into the chat box, you can click on that link to get the closed captions. So today we're going to be talking about the impact of the COVID pandemic on marginalized populations. And I am going to turn it over to Dr. Murphy. That will start us off.
Thank you very much, Professor Vrem. And I'm delighted to see everybody here today, but I'm more delighted to introduce our keynote speaker, Dr. Dianna E, who's the health officer for Charles County Department of Health. She's got a really, really impressive educational and professional background with an undergraduate degree from MIT, medical degree from Tulane University School of Medicine. She's a board certified pediatrician and she's practiced in Charles County for over 25 years. She's a professor of practice at the University of Maryland School of Public Health, and she participates in practice-based research with the Academy of Pediatrics. She served as the health officer for Charles County from December 2012 to August 2018, and then she moved on. But while she was with Charles County, her leadership really guided the health department to a really important direction. And she focused on increasing access to marginalized populations, especially access to dental, behavioral health, and primary care services. And one of her proudest moments was when she was able to bring primary care back to Nanjemoy by opening a family medicine clinic in the community center. From there, she went to the Children's National Hospital and the Pediatric Health Network, where she served as the medical director for network management. And then the global COVID-19 pandemic happened. You know, my mother always said that character tells during difficult times. When things get tough, you get to see what people are really made of. And in the midst of great uncertainty and a rapidly accelerating COVID positivity rate in Charles County, Dr. Abney chose to return to lead the Charles County Department of Health. That's character. That's leadership. Recently, I had the privilege to speak on the phone with Dr. Abney, and I was struck by her strength and her kindness. Those are both much needed qualities in this very confusing world we're in. And as busy as she was, in fact, she was on her way to meet with Governor Hogan, she took the time to speak to me and to answer my questions. I have to say, as a resident of Charles County, I'm personally grateful to Dr. Abney for her work, which she approaches with conviction, passion, and humility. And I am grateful to welcome our keynote speaker, Dr. Dianna E. Abney.
Thank you, Dr. Murphy, for that wonderful introduction. Dr. Abney, I am going to turn it over to you to start our address today.
So this is kind of what we're going to talk about today, ladies and gentlemen. Just a little bit of, but we're not going to introduce me because I've been introduced. We're going to talk about COVID-19 a little bit. We're going to talk about the impact of the pandemic, a little about vaccinating, and I'll give you an update when we talk about vaccinating on what you've heard on the news today. And we'll talk about looking into the future a little, okay? So what is COVID-19? So what you see at the top right is a picture that you're used to seeing. That's an artist representation of what COVID-19 looks like. And it's actually in the same family as SARS, which you might have remembered from 2002 to 2004, which was an epidemic that was in East Asia. It actually had, it was from cave bats and it infected humans, so it was a zoonotic spread. It was also the same or family as MERS, which was Middle Eastern Respiratory Syndrome, which was a little bit later and still does have some outbreaks now, but they're less than 1,000 cases. So it's related to that. it's also related to common cold type viruses that we see circulating all the time. But none of those have actually been as bad of an actor as our friend, or not so much friend, COVID-19, or as it's really called, SARS-CoV-2. So this particular virus was first identified in Wuhan, China, and it's thought to have transferred from some animal to humans. And it is a single-stranded RNA virus. Now, if you'll look to your right and you look at the black and white picture, that is actually a more correct representation of what SARS-CoV-2, or as we lovingly call it, COVID-19 looks like. And you know that it's called COVID-19 because 2019 is when it was discovered. All right, so what you see going around the edge there, those little knobs that stick out, those, if you sort of cut one in half and just look at it from its diameter up, those look like the little diamonds that are sitting upon a crown. And that's why coronaviruses have the name coronaviruses, because they look like a crown. So let's talk about COVID infection and what is COVID. What is COVID-19? So COVID infection I'm having trouble playing with my slides, I'm sorry. So COVID infection, it looks like a respiratory illness. And for some people, it is just that. It's just a small respiratory illness. And some people are asymptomatic. I'm sure you've heard about the asymptomatic carriers, people who really don't know that they have COVID-19 and who actually just feel like they have a bad cold and unfortunately are able to spread that virus to other people. And the symptoms are, in general, illnesses that are fever, coughing, chills. One of the telltale things that might make you think that this is different from a regular cold or a mild flu is a loss of taste or a loss of smell. And we can have trouble breathing, body aches and pains. This particular virus is very easily transferred from human to human. And the most common way it's transferred is through aerosolized droplets. And in fact, that is exactly why wearing our masks and keeping our distance makes a very big difference. And I'm going to interject in here, when we're talking about social justice, this is also a problem for some people who actually don't have the advantage of living in a place where there's not crowding, because when you live in a home where crowding is concerned, it becomes much more difficult for you to avoid being in close contact and potentially spreading aerosolized droplets to each other. Or when you work in a situation where you have to work very close to other people and you don't have the ability to separate from other people. It is less likely to be transmitted from surfaces. You will remember that when we first started worrying about COVID-19, we were all running to the store and buying tons and tons of Clorox wipes, and we were putting our groceries out in the garage and leaving them there for 3 or 4 hours and wiping the bag down with Clorox wipes. And we might have been doing a little bit, but what we know now is it is not as easily transmitted from surfaces as it is from respiratory droplets. I'm not saying you shouldn't wipe things down, because wiping things down gets rid of COVID-19 and other viruses, but that is not its main way of transmission. And is, of course, more easily spread indoors, in small spaces, in places that have less ventilation, and places where there are more people congregated. So for most people, they recover from COVID-19 in about 2 weeks, maybe 2 to 3 weeks. But in some severe cases, of course, people are hospitalized. And some of the people who are hospitalized, especially those who are very, very ill, can be in the hospital for weeks to months. You've heard about people who've been in the hospital for 3, 4, 5 months, people who have been in the ICU for a long time, and people who've been ventilated. And then we also hear about the people who, in certain cases, become what we're calling long haulers, those people who have long-term symptoms some sequelae that last after they seem to have recovered and are out of the hospital. And some of them complain of having brain fog, of having some neurological issues, and even having some mood changes. We don't know exactly what's causing these things, and people are still looking at what's going on there and why there are some of the so-called long haulers. And when COVID-19 does lead to death, it is usually through complications of our breathing or through pneumonias. So how do you treat COVID-19? So for the benign illness, or the one that is sort of the mild illness, you can just treat that at home. Just symptomatic treatment, just like you would if you had just a regular cold or a flu. You want to stay well hydrated, you want to rest, you can use over-the-counter medications to keep yourself comfortable. You basically treat the symptoms and you rest and sleep and just try not to overdo it. But for people who have the serious illnesses, the people who are hospitalized, we have a lot of things that we can do now. So one of the things that you can do before it gets very bad, especially for a person who is at risk for severe illnesses, we can give them monoclonal antibodies, which we actually can do right here in Charles County, down at Charles Regional Medical Center. And basically that is antibodies from the plasma of people who have recovered from COVID-19. And in fact, we've heard people say, after I got the infusion, I actually felt better by the time I got home. Now, they weren't cured, but they actually felt like they were feeling better. They could feel a change. And this prevents it from going on to be a severe illness for many people. And then there are antiviral medicines like Regeneron, which our former president got when he was in the hospital. And then you've heard about using steroids. And of course, there is supplemental oxygen, which helps with the breathing. And for people who are having very serious illnesses, there's ventilator-assisted breathing. Quite often, people who are ventilated will have a longer time and may have a more severe illness. And unfortunately, many of those people will die. So let's talk a little bit about the pandemic itself. Even though it originated in China, it has a high level of transmission, and it led to a global pandemic. Basically, it was a bad actor who was able to spread from country to country and from person to person very quickly. So in January of 2000, Wuhan locked down. And if you go from top to bottom, and I know this is hard to read, and I'm going to skip through them pretty quickly. By February, there was the first major outbreak in Milan, Italy. And then by the time you get to March 11th was when the WHO declared this a pandemic. Later in March, the Olympics were postponed. By the time we got to July, there were 10 million global cases of COVID-19. By the 22nd of September, there were 200,000 deaths. By the time you get down to late December, you have Moderna and Pfizer getting their emergency use authorization, and you have, at that time, you have 10 million deaths. And now we're where we are now, and we've just passed the 1-year anniversary of us being in a pandemic. So this is a very long haul that we've been on trying to get ourselves through this pandemic. So what are the global impacts? So it has impacted trade, travel, and economics for many countries. And we've seen what has happened here in the United States. We've had job losses, primarily affecting people who are of lower socioeconomic groups and to the sort of middle class. Many of us have learned to do our lives in a different way. We've learned to move in our homes and do everything remotely, from education to working to even visiting with our friends and family. And so for education, what we've seen for many of our children is the isolation and not being together with their friends and not being able to see people has actually caused a lot of anxiety and a lot of depression in children. And many children, often children, once again, who are in lower socioeconomic status, either are in families or in homes where there's no computer, or there's one computer and mom or dad needs that computer for work, or 2 or 3 children need to have a computer for work, for school, or they're living in areas where there's no broadband access, or there's no way for them to have a stable internet connection. Luckily, though, many schools, like the school system here in Charles County, have had the ability to lend Chromebooks and other computers to children so that they can do their education. And then there's the problem of our essential workers. Primarily the hard-hit people in that situation are also people who are in lower socioeconomic brackets, and there are also people who have recently migrated to the United States. And all over the country, there are migrant workers. And here in Maryland, on the Eastern Shore, right now, the migrant workers are here and they're coming to work on the crops. We see this in California, we see this in Florida, we see this in Texas. One of the good things about what's going on here in Maryland as far as the response to the COVID-19 vaccine is we are actually being able to provide vaccinations to the migrant workers through mobile clinics down on the Eastern Shore. So what about the disparities within COVID-19 for the Black, Indigenous, and people of color? So there are quite a lot of disparities. And if you look here from the right to the left to the right, you'll see American Indian, Alaska Natives, and who are non-Hispanic, non-Hispanic Asians, non-Hispanic Hispanic African Americans or Blacks, and Hispanic people or Latino people. If you look at the cases and compare them to white people, Native Americans have a 1.7 time chance of having cases. Asian, about 0.7 times more, African Americans 1.1, and Hispanics 1.3. And if you look through for hospitalizations and also of deaths, this carries on through. And what you see is Native Americans have a higher hospitalization rate. They also have a higher death rate. And if you look at African Americans, their death rate is almost 3 times as high as their Caucasian colleagues or neighbors. And for Latinos, their hospitalization rate is 3.1 times. So that tells us there's some disparities here and some things that we need to be looking at. And it also tells us when we're going out with vaccinations, we need to think about making sure that not only do we vaccinate our older population early on in the vaccination process, but we also need to think about getting to the populations who are more affected by COVID-19 in cases, hospitalizations, and in deaths. So let's talk a little bit about societal impacts on the origins of COVID-19. So COVID-19 was originated in China. And unfortunately, there has been a lot of racism and blaming of Asian Americans because of that. It's been called the China virus, the Kung flu virus, the Wuhan flu. And we've unfortunately seen people being attacked, people's businesses not being frequented, and people's businesses even being damaged because people are blaming Asian Americans and other Asians who are here in the United States for what's going on. So we've actually seen some preliminary reports that show that there's been a significant increase in anti-Asian hate crimes, almost 150% increase in 2020. So we're still looking at data, but there seems to be a trend that is very concerning. A little more about disparities. If you look on the left, you'll see cases by age, and you'll notice, and this is probably maybe a little difficult to see, but what you'll see is in the middle there, you're looking at the ages going down from the youngest to the middle, and in the middle, on the left side, you're looking at the age ranges that are in the 20s and 40s, the 50s, the 60s, and you see that most of the people who have cases are in young to middle ages. But then when you look to your right, where you see the percents of death by ages, you'll notice that those are clustering around the bottom of that chart. And what that's telling us is, even though most of the cases are in the middle to younger people, most of the deaths are in our older people. And in fact, what we see here is that even though about 80% of the cases are in younger people, about 80% of the cases are in younger people. When you turn it the other way, 80% of the cases are in, I'm saying it backwards. When you look at the percent of deaths, right. So older people are about 11% of the cases of COVID-19, but they are 80% of the death. Cases. So there's a disparity there also. So we're doing a little bit of a switch, and let's talk about preventing the spread. And globally, we've seen the same mitigation guidelines everywhere. And in the places where people use those and follow those instructions, you see a very big difference in how the pandemic has affected those societies. So social distancing, hand washing, restricting travel, both local and international, masking and wearing those masks correctly, not wearing them under your chin like a beard or right under your nose like a mustache. Restricting indoor activities, including dining and gatherings, and some restrictions on outdoor activities, and then vaccines. So if you look at some of the places in Europe where those things didn't happen early on, you saw large amounts of infection and large outbreaks, just as you do here. But then if you look at other places where people actually did the things that were asked of them, such as New Zealand and Australia, you find that the number of cases was very low and the number of deaths were very low. New Zealand actually had, the last time I looked, had only 25 deaths from COVID-19. And you'd say, well, it was an island. Yes, it was an island. But even on an island, the fact that they had any deaths mean that COVID-19 did get there. It's just that they did the things that they needed to do to prevent the spread. So let's talk about the vaccines. There are 3 vaccines that have emergency use authorization at this time: Moderna, Pfizer, and Johnson & Johnson. Moderna and Pfizer were the ones that received it first, and they are the same type of virus, and we'll talk about the types of virus in just a minute. But if you look at their effectiveness, and this is overall effectiveness, they are 94.1% for Moderna and 95% for Pfizer. They both require a second dose. Moderna gets their second dose after 28 days and Pfizer after 21. The storage temps are a little bit of a problem with these two. They need to be at minus 94 degrees Fahrenheit for Pfizer, although that has changed. They actually can bring it up a little bit. And Moderna also needs to be frozen. There's an age difference. Moderna is for 18 years of age and Pfizer for 16. They both had a pretty decent and about the same sample size of a little bit over 30,000 and a little over 43,000. And they both had a really good racial diversity, and racial and ethnic diversity of 37% and 30%. And then there's Johnson & Johnson, which is a different type of vaccine. It is a viral vector vaccine, and we'll talk about that in a moment. It's got an overall between 76 and 85% effectiveness. It does not need a second dose. Its storage temperature is room temperature. The age is 18 age and older. And it also had a very similar sample size and a similar ethnicity and ethnic and racial diversity. Now, there's one thing that all of them have in common. And the one thing that they all have in common that is the most important thing is that for severe illness, hospitalization, and death, in the studies that were done, they were 100%, all three of them, 100% effective against severe illness, hospitalization, and death. So let's talk about the vaccine technology. So remember, Moderna and Pfizer are vaccines that are mRNA type vaccines. So basically, the vaccine particle has little pieces of messenger RNA. And basically what it does, it is an instruction packet or an instruction manual. And it tells your body, or it tells your cell, how to make something that looks like the crown. And once it does that, your body makes antibodies to it. And then your body's immune system actually sort of remembers doing this, so that once your body sees a natural infection with coronavirus, it recognizes those crowns, and it then goes and it fights off that infection. So on your right, you'll see a schematic. Those little green bubbles at the top are actually the vaccine particles, and the squiggle inside is the messenger RNA. So it comes over to your cell, it gets incorporated into the cell, and then the mRNA, which is in there, goes to work. And what it does is it teaches your cell how to make spikes, which you'll remember were around the outside of the virus, and parts of spikes. And once they're made, they migrate to the edge, and then they look just like they did in the picture or in the electron microscope that you saw. And you have something that looks like the crown. And your body then makes antibodies to it, and it remembers it. So the technology in Johnson & Johnson is a little bit different. It's what's called a viral vector. And what they use is a weakened virus, and they actually use a weakened cold virus. And it's weakened so it won't make you sick with the cold. And it carries in the instructions of how to make the crown, or the crown spikes, or the pieces of the spikes. And once it goes inside, it releases the mRNA, and then the process becomes very much like the process of a pure mRNA vaccine. And it goes through the same process. It makes the spikes, it makes pieces of the spikes, they migrate, your body sees it, it makes antibodies to it, and it remembers having done that. So that once you're exposed to the coronavirus, then your body says, aha, I know what to do with that. So the three vaccines, as I said, are authorized for emergency use. And then the other thing we're going to talk about a little bit is about vaccine hesitancy. And I don't know if you can see this very well, but if you look to the right, we talk about the percentage of American adults who said they either definitely or probably will get a vaccine to prevent COVID-19, or who have already received at least one dose. And what you see is a little bit of a difference. Let's look at race and ethnicity. And what you see is that more Asians said that they were definitely or probably would, than Latinos, than Caucasians, and then down lower are African Americans. If you look at it by family income, people in the upper echelons are more likely to get vaccines, middle a little less, and lower just a little less also than that. So what you see is that there are quite a few things that make people a little less likely to get vaccine. So there are things that we can do to make a difference in those vaccine hesitancies. Those can be access to public health, education, and instilling trust and being transparent in what we do. So with public health, going out and bringing the vaccine to people, talking about the vaccine, educating them on the safety and how it works and the effectiveness of the vaccine, and being trustworthy and being someone that folks recognize and people say, well, these are people who have helped us with other things and have a relationship with the community, makes it a lot easier for people to overcome vaccine hesitancy. So let's talk about vaccine equity. So the WHO has an online campaign called #VaccineEquity. And basically its aim is to overcome the pandemic and the inequities that are the root for so many of the global health challenges that we see, and also will change the global health recovery. In the United States, the CDC and HRSA, the Health Resources and Service Administration, work together to allocate COVID-19 vaccines to the HRSA centers, specifically targeting people who are adversely affected, who have less likelihood of getting the vaccine. And so they target people who are have more disparities. So people who live in public housing, migrant and seasonal workers, people who have less English proficiency, people who are areas that have high populations of people with low income or of minorities people in rural or frontier areas, people in urban areas or in tribal areas or in Indian health programs. And they also utilize mobile vans to deliver services. In Maryland, you've heard the governor talk about his Maryland Vaccine Equity Task Force, which is led by Brigadier General Janine Burkhead. And basically what the task force does is it provides technical assistance and vaccines to entities to decrease the disparities of vaccine in our state. And those entities don't have to be health departments. They can be community organizations. They are often partnering with health departments because to be able to provide nurses and to provide storage of the vaccines, but they don't have to be, and it doesn't have to be led by a health department. And all of the counties in Maryland have actually had to put together a vaccine equity plan to figure out and to show how they plan to make sure that we have an equitable distribution of COVID-19 vaccine in our state as a whole. So let's talk just a tiny bit about the Charles County Equity Plan. And this is it sort of boiled down. So our goal, of course, is to decrease the vaccine disparities and to make sure that the distribution and the access is more equitable. And the people that we're making sure we reach are those over 65, people who have language barriers, people who have economic or transportation issues, people who live in congregate living facilities like group homes or in nursing homes, individuals who have disabilities such as developmental or physical disabilities, and then racial and ethnic minorities. And the outcomes of what we're trying to accomplish, we want to make sure that we increase the numbers of vaccination. We want to decrease the amount of COVID cases, hospitalizations, and deaths. And then we also want to make sure that people get adequate education about COVID-19 vaccines and that they understand mitigation strategies. And the reason this is so important is what we find if you look at data is that the people who are in these particular groups are often the people who suffer more from COVID-19 and often the people who don't get the education so that they understand why it's so important to participate in vaccination. So what are we doing in our plan here in Charles County? We're working with community engagement, we're increasing the communication, and we're hosting vaccine clinics that decrease the barriers to access. So for community engagement, we have partners that we're working with, local churches, local community organizations, the NAACP. We're also partnering with local with local pharmacies and with our hospital. Then we're looking at different ways to communicate, working to make sure that our communication is not only in English, making sure that our communication is culturally appropriate, and making sure that it goes out to numerous areas and it is not all in a digital form. Everybody doesn't watch television. Everybody doesn't have the internet. Everybody doesn't see ads and information pop up on their screen. So we're making sure that we actually do old school. We send out information to people through the mail. We use the newspapers, those kind of things. We've already hosted several equity clinics, and those have been in different areas of the community. And we're also targeting in the future different areas. So what we're doing, and this leads us right into the next bullet, what we're doing is we're looking at the areas in our community where the vaccine uptake is lower. We're looking at the areas in our community where the numbers of minority people or people with different ethnicities are. We're also looking at the numbers or the areas in our community where transportation is more difficult. And using that kind of data, plus the data that we get from the Maryland Department of Health COVID vaccine summary, the data that we get here in Charles County from our epidemiologists who give us our epidemiology and surveillance reports, and the statewide data on race and ethnicity, we can target places where we feel that it's important that we bring better access and more information about COVID-19, the illness, and about COVID-19 vaccination right to people's steps. One of the other things we've already started doing is we go to homebound people and make sure that they don't have to get out. Nobody has to try to get them out to bring vaccine to them. And how will we know when we've been successful? Well, by looking at the increased number of vaccines given and the percentage of people in our county who are fully vaccinated, especially people in the groups that we talked about a moment or two ago. And by the way, I didn't tell you what fully vaccinated means. I don't think I did. Fully vaccinated means having been vaccinated with a 2-dose vaccine and now being at least 14 days out from that second dose, or being vaccinated with a 1-dose vaccine and being at least 14 days out from that one. We also think that we'll have success when we have done a number of vaccination clinics in a number of different areas and in a number of different ways in our community. For example, we're looking to do pop-up clinics where you can register on site and get your vaccine right then. And we're doing it with QR codes where you can use your phone to register. And for the people who forgot their phone or who don't have a smartphone, we'll have smartphones right there with us or our computers so that we can do it right there. We register people for their clinics not just by having them fill out a link to a computer. We also do it by calling people on the phone, and we let them know that they can call us if they need help registering. Another way we'll measure our success is when we find out that people seem to be accepting the vaccine more because they understand the need for it and because they understand the safety of it. So it's a team effort. And here you see some of the partners that we have in our efforts so far, though we expect that before this is over, this slide could be twice as long and could be 2 columns. In addition to the health department, we've got emergency services, the county government, the public schools, the sheriff's office, the mobile intensive care units, because at our clinics we have, even though we don't expect anybody to have a problem, we like to have EMTs available. We also have had a new and very good partnership, and I started to save this for last, but I'm going to go in and mention it now. We have a new and very good partnership with you all, with the College of Southern Maryland, because if you probably know, we've been doing our vaccination clinics there. And then we can go on, but there are many other people that we're working with, down from up to and including the National Guard and the Vaccine Equity Task Force, some sororities and fraternities, et cetera. So what's ahead in the future? We're doing well in some aspects. More people are getting vaccinated. But it may be, we don't know for sure, that this may become endemic. It may become something that's stable in our population. We have variants, because just like other variants, this is evolving, it's ever changing, and we're racing to keep up with those variants. And then there's the issue of equity. And it's important that we focus on equitable distribution of our vaccine and protecting the people in our communities that are the most vulnerable. And it's important that we look at this from a social justice lens, and we look at it from an equity lens when we're figuring out how to fight COVID-19. So what about lessons learned? You guys know that social justice is about equal rights and equitable opportunities. You know, it's about equity, access, diversity, participation, and human rights. And the pandemic has showed us that when one group is vulnerable, we're all vulnerable. So the things that we have to do going forward is to make sure that we ensure that there are equitable access to the vaccine, equitable access to the treatment for COVID-19, that we invite all parts of our community to participate in getting the vaccine, in learning about the vaccine, and that we look at this as something that we all have a right to, that this is not just for those people, and that we bring things to people in a way that they can accept it and the way that they understand it. Basically, that we meet people where we are, that we make this equitable, because we all know that one size doesn't fit all. We have to look at what's in the community and what we have that can help us, help the community to be protected from COVID-19 and be able to then go on and protect other members of their own community.
So Dr. Abney, is this a good place for a couple of questions?
It is a great place, because look what's on the slide.
There we go. So Tony says, with the news of the Johnson & Johnson vaccine causing blood clots, how do you combat this with those already suspicious of vaccines?
Tony, that is an awesome question. Mm-hmm. And so the first thing I'm going to say is the same thing I was saying just now. You're going to combat that with education and transparency. You're going to make sure that you don't try to pull the wool over people's eyes, and you're going to give people data, and you're going to give people data in a way that they can understand it. So for example, if you happen to have listened to the commissioners this morning, the commissioner's briefing, and I'm so used to it being morning, it wasn't this morning, it was actually this afternoon. What I said about Johnson & Johnson, about this particular thing, is I told people what we know now. And I didn't embellish. I said, this is what we now know. And I'm going to tell you what we now know. We now know that out of approximately 6.8 million doses of Johnson & Johnson that have been delivered in the United States so far, to date, we've seen 6 of these very concerning adverse reactions. The adverse reaction that we were seeing is that there are people who have had cerebral sinus venous thrombosis, which means it's a type of blood clot that is a little bit different than other blood clots. It's a more difficult one to treat. Its symptoms are very similar to those of a stroke because it's in your brain. It happens to seem to happen anywhere from 6 to about 14 days after vaccination, and it seems to only appear, or at least from what we can tell right now, it's in women usually from about 18 to 48 years of age. In other countries, they're saying 18 to 60 years of age. So because people were concerned, meaning scientists and doctors were concerned, we're pausing and we're taking a look to see what's going on and if we can find out what's happening, which is the reasonable thing to do. And even though the numbers are small, we're doing this out of an abundance of caution. We're looking into it. But there's some other things that you need to know. This particular type of blood clot is also seen just in general. And it's seen every year in about 1 in 200,000 people. Now, if you remember what I said, it was 6.8 million people who've been vaccinated. And to date, we've seen 6 cases. That's less than 1 in a million. So we're seeing it less than we do in the general population, but because we're seeing it and we're seeing what might be an association with the vaccine, we're holding on so we can do research. A pause doesn't mean that we're not going to give that vaccine ever again. A pause means we're going to look at it, get more data to find out if there is actually an association between the vaccine and those blood clots. And that's the job of the FDA. It's supposed to be the regulators, and it's supposed to find out what's going on, because the job of the FDA and the Center for Disease Control is to make sure that the medicines and the drugs and other things that we put into the bodies of Americans is safe and effective for us. So they're pausing, they're looking, they're getting the data so that they can be comfortable saying, yes, this is effective and yes, it is safe, or so that they can be comfortable saying it is not. And the only thing that's going to tell us 100% is if we look at the data. And that's what's happening right now.
The next question is that where can we find out more about the production of vaccines? And if you have a history of these blood clots already, would it increase the risk of getting them with the vaccine?
Okay, remember I told you about transparency, right? So the first thing I'm going to tell you is I don't think we know whether or not a history of blood clots in general would make a difference, or a history of these. So that's, again, part of the information that we're going to be finding out during this pause. Where can you get more information about vaccines? And did you say the making of vaccines? I'm sorry, I missed part of that.
Where can we find out more of the production of the vaccines?
Okay. So if you're looking for information about the production of these vaccines in general, you can look to, there's some information, but not a lot, at the CDC's website. You can look at the information that is produced by the vaccine manufacturers. And then if you want to look, if you're going to be very technical, you can actually also look at some of the biology publications, the biophysics publications, the immunology publications that you could get. And since you guys are part of a school, you can probably get them through a sharing program with your library and places like PubMed and those kind of things.
Okay. Are residents of other counties able to come to Charles County to attend the vaccination clinics?
The answer to that is yes.
Okay.
The vaccinations are a federal and a state asset. Anyone can get a vaccine anywhere. Of course, most of us are trying to put most of our vaccine in the people in our own county because they're our first responsibility. So we encourage people to go to their own county where they either live or work to get their vaccines. So that is what we encourage. But as I said, you can get vaccinated anywhere. And in fact, if you look at the mass vaccination centers, you will see that people from other states have been vaccinated in those centers. So people from Virginia have been vaccinated in parts of Maryland. People in DC have been vaccinated in parts of Maryland. People in Pennsylvania who are close to the Pennsylvania-Maryland line and vice versa have been vaccinated in those states. But, as my responsibility as the health officer of Charles County, my responsibility is mostly to the people of Charles County. but I would definitely give a vaccine to someone else, especially if I was at risk of that vaccine going bad because I opened it and I didn't want it to expire, because they all have, once you open them or once you draw them up into a syringe, you can only, they have a half-life or a shelf life of which you can use them once they've been drawn up. And for most of them, it's 5 to 6 hours.
Mm-hmm. Another question is, some of my younger female co-workers were discouraged from getting the vaccine because of uncertainties about how fertility will be impacted by the vaccine. But I have not heard anything about this. Can you address the truth in this, if any?
So they did not do specific studies that I know of on fertility, just like they, with the initial studies, did not do specific studies on pregnant women or on people who were lactating, breastfeeding. However, during the studies, there were clearly women who were of childbearing age and who have since become pregnant and delivered healthy children. There were women during the studies who clearly, out of the ultimately hundreds of thousands of people, and when you go all over the world, thousands to hundreds of thousands of people who were pregnant and did not know it when they entered the study. And there were people who became pregnant after they started the study, who have delivered healthy babies. And in fact, we now know that babies are being born with antibodies to COVID-19 after having been born of mothers who have been vaccinated. So that's some data that tells us that fertility is, people are still fertile when they get the vaccine. But there were not, as far as I know, studies that were specifically done with the vaccine and looking at fertility as an endpoint.
Mm-hmm. The next question is...
one more thing I'm going to add about that
okay.
is being pregnant and getting COVID-19 puts you at an increased risk for severe illness. But we do know that to be a fact. So what we tell people is, if you are of childbearing age or if you are pregnant, talk with your obstetrician or gynecologist and together make an informed decision about what you're going to do. And most of them will say that it is safe and that you should get the vaccine because you don't want to risk your life or the pregnancy by having a severe case of COVID during that time. I'm sorry, go on.
It's okay. Have you heard from anyone who is hesitant about being vaccinated, and the reasons they don't want it is because they know what's in it? They don't know what's in it. Also, they don't want to get it because of past experiments on Black people. What would you say to alleviate those fears?
I've only heard of a few people who told me that. I know that sentiment is out there. But as I said, I haven't personally heard from very many who said that. But a couple of things that I've told people about that, one of which is the environment that we do research in today is very different than the environment that research was done in, even as recently as in the 50s and 60s. And actually, even as recently as when I was in medical school. The things that you have to do to make sure that you are being fair and safe with people, and you call them human subjects, but with humans who are in studies, are very clear. You are legally bound to do them. And they are very, I don't want to say onerous, but they're very particular. So you have to go, your study has to go through an institution review board, and they review everything that you plan to do and how you plan to do it. And if you vary from that, it becomes a problem. So people are watching very closely the whole way through you do your study. So that is one thing that I feel comfortable telling people. One of the other things that I feel comfortable telling people is that Moderna, one of the researchers, one of the people who was heavily involved in that, is an African-American physician, well, doctor, I think she has a PhD, who works at NIH right here in our metropolitan area, and who went to school at UMBC and was a Meyerhoff Fellow. So it is someone who I would believe, and I would be comfortable believing that she would not do anything that would hurt me or my people, if you will. And I think when we know, regardless to who we are, when we know that more people like us are participating in the research as the researchers or as the people who are in the study, I think that should give us more faith and trust in the work that's being done. When you know that they're not just testing or doing studies on one particular population, so that you know that for example, when you know that medicines that are being tested are also being tested on women, so that you know that the fact that you have a different hormone makeup and you have differences about your body than men do should make you more comfortable. So I think that knowing what's going on, the transparency, and knowing that there are much more strict rules about how research is done should make people more comfortable. And those are things that I share with people when they ask me about that. But as I said, I have not had very many people say to me that that is the reason that I don't want to get the vaccine.
I have another person that says that emergency use authorization is not the same as being approved. So if I have an adverse reaction to this experimental vaccine, who can be held accountable?
Right? Emergency use authorization is not
the same as being approved. So
it is not the same as being approved. That is a true statement.
Okay. So
but yeah, I heard the last part. You know, I will have to look because I don't know the answer to that, but I believe what I do know is that while we're using something or this particular things on emergency use authorization, they are following very closely for adverse effects. For example, when you get vaccinated, you are offered to join something called VSafe, which is through the CDC, which actually checks on people in the beginning very frequently, and then weeks after, and then more weeks after, and then months after. They also have what's called VAERS, which is the Vaccine Adverse Effect Reporting System, which both individuals and their physicians can report anything that they think is an adverse reaction to. But I will look and see whether or not there is specifically a person. I'm assuming when you say held accountable, you mean who can be sued. Mm-hmm. But I will look to see if I can find out the exact answer to that, and I will share it with the people who put this on. I'm blanking on Tatiana's last name, but I will share it with her.
Mm-hmm. Mm-hmm. Okay, that was a great question. Let's see, a couple more. Are vaccines encouraged or discouraged for those with autoimmune diseases?
That is an awesome question. And the answer is they are encouraged. One of the things, though, depending on what your autoimmune disease or issue is that you may know, and again, you should speak with your doctor about this. Some people with autoimmune illnesses may not make as robust of a response to a vaccine as others. So you should talk about it with your doctor. But if you already have an immune system that is not functioning at 100%, you do want to have it boosted so that you can be protected a little more against things that come towards you, such as the coronavirus. So yes, they are recommended to people who have autoimmune illnesses. That was an excellent question. Thank you.
Mm-hmm. Is there information available for lingering symptoms of COVID, coughing, shortness of breath, etc.? And will the vaccine help or make these symptoms worse?
So there's not as much information as we hope to have at some point in the future about the lingering symptoms. I'm assuming you're talking about the long haul symptoms, the people who after many, many months are still having some symptoms of COVID-19. And there are symptoms other than the coughing and the shortness of breath and being tired. There's also things like brain fog or things like just not feeling well, general malaise. And it is not clear. I don't think we have enough data to know whether getting the vaccine will make a difference in those things. It will certainly help you not get reinfected with the virus because it will boost your immunity. But I don't think we really know enough about people who have lingering symptoms of COVID-19. And remember, I keep saying that we're following the data, not just here at Charles County or in the state of Maryland. What we're doing is we're looking at the data, and people are looking to see what's going on with the people who have lingering symptoms of COVID-19. So time is going to tell us that. Okay. We've actually this has been around about a year, a little over a year. So there's still a lot to learn about this illness and what's going to be the ultimate outcome.
Are we going to have to get a COVID vaccine every year?
The answer is that we do not know that right now. However, that is a distinct possibility because of all the variants. One of the good things, though, is with the type of vaccines we use, for example, the mRNA vaccines, they are relatively easy to make and relatively easy to update. So to be able to make one for the variants should not be very difficult.
Okay. Is there a concerted effort between Maryland counties to coordinate the dissemination of information and COVID education to dispel fallacies among the marginalized population?
I don't know if I would say that there is a concerted effort among the counties, other than that we all are under the main health department, the Maryland Department of Health. And so as a result, we are all given the same information, and we do try to have some similar messaging. For example, the Go Vax campaign and other campaigns that we do, not only on this particular topic, but also on other health topics. So there is some uniform messaging that is produced in the state of Maryland.
Okay, just a couple more. How likely is the vaccine? Okay, how likely is the vaccine?
I'm yours as long as you want me.
You're wonderful. Okay,
you guys are the only thing left on my schedule for today, so have at it.
Because the questions are coming in. So a follow-up to the person that asked you about who is accountable for the experimental vaccine, there was another comment that was made that the 1986 National Childhood Vaccine Act, NCVIA vaccine manufacturers have zero liability to any injury or death. That was a follow-up statement to that other question.
Okay. As I said, I don't know what the details are, but I will look for them for you, I promise. And if I find something out.
Hope you muted yourself.
Sorry.
There you go. That's fine. Yeah, I'll make sure I post it when we get an answer.
Sure.
The next question is, how likely is the vaccine to become mandatory? How likely will people retain the right to not vaccinate themselves or children? Will not getting vaccinated ostracize people from work, like nurses who deny the flu vaccine?
That's another only time can tell answer. depending on your employer might choose, especially a healthcare employer like a hospital or something like that, might choose to make the vaccine mandatory. But it depends also on the state's laws. Different states have different laws about what you can do as far as making vaccines mandatory. Now, as far as ostracizing is concerned, one cannot mandate people to or not to ostracize people. And there will be people who will treat people badly because they vaccinate themselves or their children. And there will be people who treat people badly because they don't vaccinate themselves or their children. But as long as it is only under emergency use authorization, it will not be mandated. They can't mandate something that is under an EUA. So at least for some time, it won't be mandated.
Okay, let's see. Are there any programs in place to help healthcare workers who are dealing with psychological trauma from the increased deaths associated with COVID-19?
Again, this one depends also upon your employer. There are many employers who have programs for their employees who are dealing with death, loss, other kinds of emotional stress. So it really depends upon your employer. It also depends on your professional organization. Some of the professional organizations have things that they're offering to help people who have dealt with the stress of being around so many sick people and working so hard and working at the risk of your own life, especially in the beginning of the pandemic where we didn't know as much about it. So it's sort of case specific as to where you work and what your employer has to offer.
Mm-hmm. How critical sorry.
Oh, wait, one more thing. For example, in Maryland here, the Maryland Department of Health, they actually partner with MedChi, which is the Maryland Medical Society. They have a webinar series that focuses on behavioral health and specifically spends time focusing on how people are doing and on and the health department, Charles County Health Department, has just opened a program that should be starting. I don't remember when the first time for the webinar is, but we have webinars that are going to be available that's called Compassion Fatigue, that is available for our employees and that we're offering to the local emergency medical services, which sort of helps you recognize the stress that you've been put under because of working in this particular situation and teaches you how to take care of yourself so that you can deal with some of the stress. And sometimes you don't even realize that you're being stressed, but that you can deal with some of the things that are happening in your life because of your involvement in this heavy lift that we have had dealing with COVID-19. And that was, again, another great question. You guys are asking really wonderful questions.
Okay, there's a couple of more. How critical has it been for the vaccine to be free to all, especially for individuals and communities in financial hardship?
Oh, I think it has been key that it's been free for everyone. For example, even in places where especially in places where money is an issue and is a barrier, that goes without saying that it's immensely important. But it's also important in people who you think of, oh, Johnny has a good job, because Johnny may also have a really, really high deductible and may make choices about his and his family's health care based on the fact that it looks like he's doing well on the outside, but what's really going on with his health care is not what it looks like based on the car he drives. So it takes away a huge barrier, and a huge barrier not just for the people who we think of as middle to lower socioeconomic or income people. It takes away a big barrier for a lot of people. So it is it is really, really, and I don't know how many adjectives I can put in there, important that it is free to all people, that nobody will get charged anything for this vaccine. Would that it were the case for all vaccines in the United States, that no one was charged for vaccines.
Mhm.
That would be amazing.
Mhm.
And it's the way it should be, by the way.
Mhm. Another person asked, can we go with someone who has an appointment scheduled to receive the vaccine, even though we haven't received an email stating we can schedule our vaccine appointment?
Are you saying, can you go and hope that there might be one extra one and that you get lucky and get one? Is that what you're asking me?
It looks like it, yes.
So that does occasionally happen. It is not encouraged, but it does occasionally happen because, believe it or not, as much as people say they want to be vaccinated, as much as people complain that they are not vaccinated, we sometimes have clinics that do not completely fill, which boggles my mind. And the same is true at the mass vaccination sites. Even though, you know, they have thousands of doses available, there are some times when their appointments do not completely fill up. So it could happen, but you could also be standing there and just not be able to get an extra vaccine, because we really, all of us really try, because it's such a valuable resource. We really try to hit the number right on the dot, so that we don't have a vaccine that expires because we did not have a person there to get that vaccine.
So we have two more. Let's see. And a couple of statements. Quite a few people are saying they're about to get their first shots. Their grandparents have already gotten their shots. And a couple of people here are attending to decide if they should get a shot. One of the last questions here is, why should I trust any of these vaccines if there's no long-term study of any of them?
Because science. So one could argue that you need to study something for 20 years before one trusts it. I mean, with science, we can make extrapolations based on the data we have. We can look and say, based on this amount of data, we can make the extrapolation that this is actually true. For example, you can say that if you have X number of people in a study, then you can extrapolate that to say that this will work for a larger number of people. The other thing, and one of the things that I really want people to understand is, and people worry because these vaccines were made so quickly. And unfortunately, it had an unfortunate name, Operation Warp Speed, which was a horrible name to give to anything that has to do with developing a medicine. But this is not new technology. Remember, I said early on that this is related to the vaccine that caused SARS, just plain old SARS, severe acute respiratory syndrome, that was seen back in 2002. So we've been working on ways to combat and ways to have a vaccine for things that look like SARS or SARS-CoV-2, which is the real name of COVID-19. We've been working on this technology for years. This is not something that just started in March or in January of 2020. And this is not the only virus that we've been looking at mRNA type vaccines for. This is not brand new technology. And the other thing you need to remember about the speed of how this was done is, this was a pandemic. We've not had a pandemic of this magnitude probably since 1918, 1919. So it was an all hands on deck. You had pharmaceutical companies who used to be rivals who worked together hand in hand. You had funding agencies who said, here is money, work on this. So people stopped some of their other research because people were dying in large numbers so that they could spend most of their time working on this. So this is not new technology. It's been around for a long time. Some of the barriers to getting research done in a timely manner were removed. And all of these things, when we do studies and then we extrapolate from the study we did to whether or not it would work for a larger population. Again, you guys are asking great questions.
Okay, let's see what we have. So this is still a person that's on the fence. Are the risk of people dying from COVID greater than the risk of not being vaccinated?
Yes, 1,000 times yes. In fact, again, I'm going to go back to what I said this morning this afternoon on the commissioner's briefing. What I said was that the state of Maryland, Charles County, most of the state of Maryland and Charles County are still in a high transmission state for COVID-19. In the last 24 hours, there have been 31 new cases of COVID just here in Charles County. Just in Charles County. There have been over 100 in the state. I can't remember the exact number, but Amber's sitting here. She's probably going to write it and hand it to me. And 13 people were hospitalized in the last 24 hours. So it is indeed a risk of dying. So remember I told you that the risk of the type of blood clot that we paused Johnson & Johnson for was less than one in a million, that in the background, just on an average time, 1 in 200,000 people get that particular problem. Right now, this week, 17 in 100,000 people get COVID. That's the rate we are here in Charles County. The rate of getting COVID in the state of Maryland is 22 per 100 county. In Baltimore City and Baltimore County, it's in the high 30s. In the last week, we have had 201 new cases of COVID-19 in Charles County. In March, there were 18 deaths from people in Charles County alone. That is not counting the rest of the state of Maryland. That is not counting the rest of the Tri-County here in Maryland that we think of. That is not counting the rest of, not even the whole DMV, just the metropolitan Washington, D.C. area. It is much, much safer to get the vaccine than not. People still die. People still get hospitalized. People still have bad outcomes from this illness, which is preventable by vaccine, or at least the severe outcomes, and which is less likely to be spread by people doing the things that I've repeated many times: washing their hands, watching their distance, wearing their masks correctly, and avoiding large crowds. The flu. How many people do you know that have had the flu this year? Respiratory drops are stopped by that barrier, that mask. So we've not had flu to speak of in the state of Maryland this year. So there are things that we can do to make a difference, and vaccines are just one of the arrows in our quiver for stopping this pandemic and making it safe for all of us. Another great question. Thank you for asking it.
Well, we're out of time. I wish we had more time. This was wonderful, Dr. Abney. I hope that this will encourage everyone. I am vaccinated. Dr. Abney's vaccinated. Dr. Murphy's vaccinated. It is very, very important to get your vaccine, because the research is showing Like Dr. Abney said, it's safer to have it than not to have it. You can survive COVID if you get it, if you're vaccinated. So Dr. Abney, thank you so much for being here today and taking the time out. Amazing presentation with lots of information. And we will definitely have some follow-up answers. I will send it out to the list of participants that asked certain questions, okay?
Great.
Thank
Can I
you
add
all.
one more thing that might
Yes.
help people decide?
Okay.
Some of you may know, that you probably heard in the beginning, I'm a pediatrician by training. And I have a set of twins. My twins, I was old when I had them because it took me a long time to get pregnant and stay pregnant. And then I was on bed rest for 8 weeks before they were born. The last 5 of those 8 weeks were in the hospital, and I'm hyper, so being in the hospital and being in the bed was torture. And they were born prematurely, and they spent almost a month in the hospital after they were born. I gave those children not only all the rest of the vaccines, but I made sure those now young adults got vaccinated for COVID-19. There is nothing that I would offer to you or any other person that I would not offer to my children. And after the story that I told you, actually it's the truth, after what I told you about what it took me to get those children, you can pretty well be sure that I would not do anything that would be detrimental, that I believed would be detrimental to them.
Thank you, Dr. Abney. Very, very much. Very well said. All right, everyone. Thank you so much. Wonderful presentation. And we will have this on the website for anyone that wants to watch it again. Okay. Have a wonderful afternoon. Thank you all.